everybody. Recording live from somewhere. This is Zach, couples with episode number 133 of the Movement Debrief. And today, folks, we're going to talk about things in an order that would surprise you. Because we're going to talk about movement limitations and which ones to go after first. If you are confused as all hell by terminology that I use or other people use, or you're like, okay, I did all this testing, now what? This is the debrief for you, ladies and gentlemen, boys and girls, children of all ages, because your boy, Big Z, has got a bunch of questions that have been asked by the people. They will be answered for the people by this people right here. Fam, recognize fam. Without further ado, let's debrief, shall we? The first question comes from Andrew. And here's what Andrew asks. Hey, Zach, I am a little confused by this wording. An exhalation biased spine compensates with an inhaled wide infrasternal angle. If they are in an exhaled state, wouldn't that mean the ISA would present narrow? Thanks. Amazing question. I've moved a bit away from the inhalation-exhalation terminology because it's kind of confusing. And it requires you understanding what normal respiratory mechanics are. And so if you don't have that requisite understanding, well, you're kind of SOL. So let me give you some S so you can get L, if you know what I mean. So inhalation, exhalation, spine. When we talk about that in particular, this person's using an inhalation strategy or an exhalation strategy. We're talking about components of normal respiratory mechanics. 1, 2, we're using the axial skeleton, the spine, as the reference point. Think of a normal, I'm going to scare quotes the hell out of normal, a normal spine having alternating curves of kyphosis and lordosis. Kyphosis would be present in the sacrum and the thorax. Lordosis would be present in the lumbar spine and the cervical spine. From that position, if you take a breath of air in, imagine this force that's pushing all of the curves posteriorly. What I mean by that is, boom, I got viscera downstairs pushing the sacrum back, counternutation, reducing the lumbar lordotic curve because that's getting pushed back. If I had a thorax, that would also be pushed backwards as well. So you potentially might see like an increase in general kyphosis. You'd see a reduction in the lumbar lordosis, so on and so forth. So that's an inhalation strategy. And generally within the body, you're going to see expansion or the entirety of the body getting bigger. External rotation is going to be driven, lots of things like that. But for our intents purposes, since we're talking about nomenclature, focus on the spine. With an exhalation-based strategy, you get the reverse of that. Now, to squeeze the air out, I'm going to compress the body in all directions. You're going to have now an anterior-directed force, bringing the spine back to its normal resting position. So you'll see from the inhaled position a sacral nutation. You'll see a return of the lumbar lordosis. You'll see a reduction of the thoracic kyphosis, so on and so forth. In the case of someone who has a restriction of movement options, we would argue that there is likely a restriction in respiratory variability because every time you breathe in and breathe out, the body has to move. So if there's limitations in that mechanism, you got problems. Your two strategies are either being more biased towards the inhalation side of things getting pushed backwards, roundedness through the spine, or you're more biased towards the exhaled side of things. Back is more flattened. Forces are directed anteriorly. Now, you still have to be able to complete the other end of the respiratory cycle. If you're more inhalation biased, well, you still got to exhale. But what if the normal respiratory mechanism wasn't available to you? what if you couldn't reverse the curves of the spine? You still got to finish the breath. So how are you going to do that? Well, I'm glad you asked. That's where the compensatory breathing strategy comes into play. And one of the first places that you'll see this will be at the lower rib cage. That's why we measure the infrasternal angle, and it's so important. And why the lower rib cage? Well, due to the lack of the common sternal attachment, you have this connections, the false ribs, so they're connected to the costal cartilage, the floating ribs, the flautas. They don't have any attachment. So there's a lot more flexibility in that area to adapt to potential compensatory strategies. If you want to learn more, Diane Lee's got a good article that talks about this. I'll link it in the show notes, which will be found on zachcouples.com/limitations. And also, if you're tuning in on that Instagram, baby, you definitely want to check it out, because I don't know if y'all know this, I've been also blogging and writing like some nice blogs along with this to help support your learning, because I care about you that much. So more flexibility in the lower rib cage. And if someone is more inhalation biased, they can utilize an exhalation strategy to try to complete the respiratory cycle. But now we've dived into compensatory mechanics. Instead of having that circumferential and multi-directional expansion and compression of the body when you breathe in, now you got a situation where I have a stagnant spine or ventral cavity, and I'm getting more of the motion through the lower rib cage. So an inhaled spine will compensate with an exhaled lower rib cage. That is a narrow infrasternal angle presentation. Caveat with that: just because the lower rib cage is exhaled, it doesn't mean that the diaphragm has fully ascended. It just mimics the position of an exhaled diaphragm. So think about it this way. If I'm using an inhalation spinal strategy, that means I'm going to have air in the lungs. The diaphragm ascending helps evacuate air. So if you got all this air cramping up your stelo in the thorax, well, you might not be able to push it out because of compensatory strategies. So the other option, to mimic the narrowing of the lower rib cage, would be to descend the diaphragm even further. There's a good article, journal article that was done by like the OG himself, Andre Detroyer, where he talks about how if the diaphragm flattens or descends towards flattening, the pull that it has on the lower rib cage inverts. Under normal circumstances, the rib cage would move outward and upward, the bucket handle mechanism. When it goes to flat, the attachment of the diaphragm pulls the rib cage inward. That's how you can get the narrow infrasternal angle. Narrow infrasternal angle is a compensatory measure for an inhaled spine. An exhaled spine, forces pushing everything anterior, nutated sacrum, increased lumbar lordosis, flat AF T-spine, what you gonna do about it? That person, to exhibit compensatory respiratory mechanics, will instead have an inhaled lower rib cage. That's your wide infrasternal angle. So you can see the ISA is a compensatory mechanism for what the spine cannot do. You can see how that's kind of confusing because you have to have some understanding of the respiratory mechanics. 1. 2, another reason why I don't use this as much is I don't want people to think that because I have this inhaled strategy, can I push my ISA so I have a crazy exhaled strategy? Because if you look at articles like the torso integration hypothesis, or there's this really good book that I've been diving into called, I was just reading it on the plane actually, Body Mechanics in Health and Disease by Goldthwaite. I don't know how it's pronounced, but this will be in the show notes for sure. A lot of this is structural in nature, and we can look at this from like a respiratory dynamic standpoint, but the reason why you have these specific biases has to do with your build and your anthropometrics. This matters, and I think this is much more meaningful because now we can work with people's movement restrictions based on these structural biases that people have. And we can look at it from this respiratory standpoint, from a nomenclature perspective. But what I find easier, personally, is looking at it as one of two things. So you can either, if I'm looking at a lateral view, you can look at it as either this person is more biased towards being concentric on the back, or this person is more biased to being concentric on the front. And this has to do with the compensatory strategy a person is going to utilize to maintain upright posture, among other things. For the person who's got a narrow infrasternal angle, inhaled axial skeleton, remember, forces are pushing that spine backwards. So if you don't want to fall, you're going to concentrically bias stuff on the front to upright you. That's the first layer of compensation. So narrow ISA, inhale axial skeleton, concentric on the front. Eccentric on the back. Unless there's a secondary compensation, stay tuned, we'll talk about it. The wide infrasternal angle, they're getting pushed forward because of the exhalation strategy. So sacrum's going to nutate. I don't want to fall, so in order to prevent the fall, I'm going to concentrically bias stuff on the back to upright me. Concentric on the back, wide infrasternal angle, exhaled spine, eccentric on the front. To me, that is much easier to think about. And then we can think better about what we need to prioritize from an intervention standpoint by thinking of it that way. I think understanding the normal respiratory mechanics are important, but because we deal mostly with compensatory, and a lot of this is anthropometric bias, I have moved a bit away from using this nomenclature, and I think it minimizes confusion. If you're a narrow, your first bias is concentric on the front. If you're wide, your first bias is concentric on the back. And if you have either of those problems, go ahead and talk to Zach. Awesome question, Andrew. Let's see what we got on IG. I saw some stuff. People were talking. Hey, man. That's what I'm going to call you. I'm sorry. Can you help a person having jaw and visual issues? So if someone's got something that's driving movement restrictions in the jaw or the cranium, can we make positive influences on these people? The short answer is it depends, but let me unpack that so we have a bit of a longer answer for you fine folks. What I find with most people, if they do have some jaw or some visual issues, more often than not, you can at least get some semblance of change. It may not be long lasting, but the number of people who I was like, there's no way that I can change them is few and far between. In fact, if I think back to the last 3 years, I've probably had a client, it's probably a client a year where I couldn't get any or minimal movement changes whatsoever. And I thought it was reasonable to refer them on the dental path or the visual path. There was one guy recently, actually. He had this recurring neck pain. And it just like, he thought it was from an accident of some sort. And he was getting his phone, so he pulled out his cell phone, and he was like doing this to read it. I'm like, that's interesting. What's going on there? And I said, does it hurt when you read? And he said, no. I've had to do this since I had LASIK eye surgery. I said, oh, you didn't mention that on your medical history stuff. Why do people do that? Anyways, so this guy, he had LASIK eye surgery that was botched. And it gave him monovision, so he had one eye for close, one eye for far. And he kept getting right neck pain. And he had to always turn his head to the right and compress down so he could view his phone or his computer monitoring and a computer job. And we did a bunch of things, couldn't seem to get much change. And, unfortunately, I think he had like a couple other redos on the surgery, did not go well. This was like the best it got. And I said, man, this is tough. I told him, it's like, I just because I didn't want to waste his time or money, it's like, look, I think I can help you, but I don't think I'm the person for you right now because you have these visual issues and you might benefit from vision therapy. I mean, that was my initial recommendation. I don't think he took me up on that offer. That's something I struggle with too, is like when you broach these conversations about cranium versus jaw, is they're expensive if you want to do it right. Your results aren't guaranteed. Results aren't guaranteed with anything, of course, but there's the evidence on this stuff is still murky. And I say that being someone who's getting his mouth blown open to see what it does. So I think you have to be careful about pushing people to that very quickly, because in that case, maybe there were some things that I could have done and I didn't give them my best effort. I don't know. Maybe my bias to, once I heard that, I just was like, okay, there's no way I can help them. Maybe that didn't get the outcome I wanted. We just don't know here. But I think with this stuff, people push to doing those types of treatments way too quickly, because most people, the overwhelming majority, and I've seen this countless times, they do not have mastery of the basics. They can't stack. And yet they're talking to me for some reason. What the heck, fam? But if you don't, like, I've worked with some people who've gone down the dental route, who've gone down the vision route. No changes in symptoms. No one taught them how to exhale along the way. And to me, that's a disservice, because the human body is very adaptable. We can morph and change to a lot of different things, and that includes cross bites and the like. And if you don't rule out just coaching the basics and making sure that they can get in the positions they need to, I don't think that person's justified in going down that route. Especially when you go down the vision or the dental route, a lot of the activities become a little bit more challenging. So if you don't have the fundamentals in place, you're likely wasting your time. The one case where I will say I circumvent that issue is if there are glaring symptoms that would warrant pushing someone down that path. What I mean by that is not you have a loss of shoulder internal rotation or something like that. But if you got sleep apnea, if you got upper airway resistance syndrome, if you're grinding your teeth at night, that probably warrants further referral. Maybe it's getting a sleep study. Perhaps it's working with the dentist, could be with an ENT. If you have that person who's had LASIK eye surgery that's been botched and they haven't done vision therapy, I think that probably warrants a referral as well. Or if you have someone who you think has like a strabismus or a lazy eye that was never treated, I think that's when you refer to those things. And it's not because you're trying to improve their movement. That can happen as a secondary consequence, but it's because that's totally in the wheelhouse of those domains. No one gives a shit about your hip internal rotation if you have sleep apnea, because that's going to kill you. Loss of hip IR won't. You need to address concerning medical things as early as possible, and that's when I think doing these types of referrals is most important. So if you are someone who potentially has a jaw issue, exhaust all conservative movement measures and exercises as far as you can before going down that route, because you're likely going to get a better outcome if you inevitably do, unless you have some type of medical issue that would warrant a referral to those people. Awesome question. Amen. Ruben Rothel 3000. Any relation to Andre? We usually focus on helping clients shift into their left side since they are buried in their right side. I've heard that sometimes, but you need to integrate right side before you address the left. What does that mean? First off, I don't like telling people they're buried in their right side. I definitely don't tell that to clients, because I've seen the ill effects of people being told that, and then they obsess with this, that I can't get out of my right, I can't get out of my left, and I've spent the last 2 years working on my left side and nothing's going well. That's probably not what's going on. First off, bones don't touch. There's a good research article there that I'll share with you that discusses that. It's a really cool study. So I don't know how we can be buried in that regard unless you have a major structural abnormality. What can happen is you can have a restriction in movement in many directions, and that can make it very challenging to restore movement capabilities on both sides. But when someone says integrate a right side before you address the left, what I think is more important than that is you have to be able to do things well on both sides. That's why the stack is so important from a coaching standpoint. Because anytime you go single leg or you throw in reaching, single arms or shifts or anything wild and crazy, it's a lot harder. And people jump to that way too quickly before they have the body awareness to be able to do that well. So it's not a matter of going right first and left. It's a matter of doing things well on two legs, because it's easier to teach things on two legs, and then making sure you do things savagely well on both the right and left side. Because guess what, folks? Things aren't as clear and dry as you have this restriction on the right and this restriction on the left. Most people are limited bilaterally. So let's keep it real. Let's not work with this pie in the sky thing that we see once a millennia in terms of this particular pattern. Look at the limitations that your person has in front of you and address them with a lot of the interventions that I have on my site or the stuff that you like. And don't worry about just focusing only on a left side or making sure you got to, but you got to get the right first and then you go left. Nah, just look at what this person can and cannot do. Give them the movement and give them activities that challenge their ability to perform the activities that they can't. And if you do that, and you build their fitness levels, a lot of times people are going to be moving better and feeling better. And to me, that is way more important than going in the sequential if this, then that. The hard thing with that is you have to test. You have to be critical. You have to challenge yourself and your biases. I remember when I was really biasing asymmetries earlier in my career. I mean, sometimes I would think that I would see this asymmetry all the time. And I think I faked myself out testing-wise in order to make it so. Whereas if you can be as objective as possible, which is hard because we're subjective creatures, and you look at what the person is doing in front of you and address things that way, I think that's much more fruitful and helpful for your supreme clientele than following a set rule of do this, then this, then this. Awesome question. Ruben Rothel, 3000. Hopefully I pronounced your last name well. The next question comes from Random Inch Bird. Here's what Random Inch Bird asks. I hope that's your real name because that would be badass. I frequently see you referring to primary and secondary compensations. I must have missed the day at university where they defined these. Any chance you could define them in one of your videos? Not having any luck finding definitions elsewhere. Well, unless you went to the University of Big Z and colleagues, you probably wouldn't hear it at your university. So let me definition it for you. Primary compensation. When we're discussing that, this goes back to the anthropometrics discussion that we had with a few questions ago. With a narrow or a wide infrasternal angle, they have a structural bias about them that predisposes them to being limited with certain positions, movements, directions. In the case of the wide infrasternal angle, remember the forces are being directed anteriorly, sacrum's going to tip forward. I don't want to fall. So the first thing that they will do to prevent the fall is to concentrically bias the back side of their body to upright them. That is the primary compensation. The primary compensation is the first thing that this person does to manage their body structure. And addressing that compensation involves manipulating the dynamics of the structure in order to restore movement options. Let's suppose I'm that wide ISA. So I fell forward. Oh, crap. What's happening? Boom. Concentrically bias my backside. And now that's pulling me too far. Oh, crap. Now I'm falling backwards. What am I going to do? Well, in order to prevent the fall backwards, you then have to concentrically bias the front side of your body. I will have to use bigger musculature to upright in that case. think of it this way. It's like the bias of falling forward is probably small enough that you can use the little guys on the backside, think your multifidus, rotatories, all that stuff, to upright. But now that I've created this gradient of I'm a little bit tighter on the back, less tight on the front, and I start getting pulled too far back, I probably got to use bigger dogs to upright me. I use an inner layer of musculature to upright me first, the primary compensation. The secondary compensation is the restrictions that manifest to upright from the primary compensation. In the wide case, they fell forward. Primary compensation was the concentrically biased the backside of the body. If that makes them fall too far backward, you're going to then do a secondary compensation, which would be to concentrically bias the front side of the body. For a narrow infrasternal angle, that's flip-flopped. For a narrow, they're falling backwards first because of the backward forces directed from the inhalation. So their primary compensation is to concentrically bias the front side of the body to upright themselves. But if I do that and now I'm falling too far forward, oh, snap, crackle, and I don't want to pop, then I'm going to concentrically bias the back side of the body to upright from that overcorrection. And that concentric bias on the backside is the secondary compensation. The primary addresses the structure. The secondary counteracts the primary compensation. And that's why we order it in that way. Is that how it actually happens? Probably not. It's likely the person's structure dictates where all the restrictions would be. But I think it is useful, and from a treatment standpoint, as we'll talk about later, effective to think of it in those terms. How do you know if a person has only primary compensations or if they have secondary compensations? Well, I'm glad you asked. This is where concentric back and concentric front are useful. Because if I have a concentric bias of the back side of the body, the posterior aspect, and when by body I mean the ventral cavity, this person will have limitations generally in flexion, abduction, and external rotation. If I have a concentric bias on the front side of the body, I'm going to have a limitation in extension, adduction, and internal rotation, ventral cavity. Now, let's look at our two archetypes, the narrow and the wide ISA. For the wide infrasternal angle, if they're concentrically biased on the back as their primary compensation, you're going to see limitations in flexion, abduction, and ER. Measures that should be clear are extension, adduction, and internal rotation. If you see someone who's a wide and they have a loss of extension, adduction, and IR, we don't have an unsolved mystery, people. We got a concentric bias on the front side and thus a secondary compensation. For the narrow, that completely flip-flops the other way. A narrow infrasternal angle, since their primary compensation is to be concentrically biased on the front, they should be limited in extension, abduction, and internal rotation. But if they're limited in flexion, abduction, and ER, then you know that they have secondary compensation at play. And that's how you can differentiate primary and secondary compensations. The last question comes from my dude, Leo. And here's what Leo asks. So treatment for a wide infrasternal angle with only primary compensations and a narrow with secondary compensations are very similar. And treatment for narrow ISA with only primary compensations and a wide with secondary compensations are also very similar. So to determine treatment options, is it almost more important just to see if that person is more concentric on the front side or back side, since the ISA is not that relevant when a person has secondary compensations? Good question, Leo. And the infrasternal angle is uber important in this primary and secondary compensation thing. Even though the limitations of a primary narrow and a secondary wide are similar, and same thing, a primary wide and a secondary narrow, the order at which they got there are different. They have a different structure. And the third thing is you have to prioritize things a bit differently in each of those cases. So let's unpack that. The first thing I want to talk about is prioritizing things differently in those cases. In order for movement to happen, we have to be able to create a gradient. A gradient is a thing where you have stuff of high concentration, so a large amount of things, moving to an area of low concentration. For example, if I had a bunch of people in somewhere studios breaking all types of social distancing because I'm a rebel, the only way that people can move out of somewhere studios and into my living room is if the living room is empty. If I got a bunch of people crowding the door, then I have no movement. These people are stuck in here. They're stagnant. I need to have an area of low concentration of people because somewhere studios is an area of high concentration of people. So if my living room was empty, well, then people could move out into the living room and disperse, and life is good. I need the same thing when it comes to movement of a human body. The way we move, instead of moving people from somewhere studios to my living room, is by alternating concentric and eccentric contractions, because concentrations change here. When I concentrically bias my wonderful bicep, there is a low concentration of synovial fluid on the anterior aspect of my elbow joint, but there's a high concentration of fluid in the posterior aspect of my elbow joint. And when I flex maximally, which I do on a regular basis, I can't move into flexion any further. What I have to do in order to induce movement is to push the fluid from an area of high concentration, posterior elbow, to an area of low concentration, anterior elbow, aka extend the elbow. That's how movement works. It works that way in the ventral cavity as well. If I'm someone who is concentrically biased on the back side of my body, a wide infrasternal angle with primary compensations, and I'm eccentric on the front side of my body, I have in the thorax a little bit of air in the back, a lot of air in the front. In the lumbopelvic area, I have the viscera, a lot of viscera in the front, not a lot in the back. In order for me to create movement within the ventral cavity, I have to push air posteriorly and viscera posteriorly. High concentration to an area of low concentration. So then, we have to ask, Leo, well, does it matter if I'm primary or secondary compensation? Absolutely. Because if you have someone with secondary compensations, you still have to respect the gradient of moving from an area of high concentration to low concentration. Let's say I have a narrow infrasternal angle with secondary compensations. Remember, if you were listening earlier, primary compensation is to concentrically bias the front side of the body. And then the secondary would be to concentrically bias the back side of the body. Well, in that case, because I'm squeezing both the front and the back, well, I ain't got much movement available because I've reduced the concentration of stuff. But consider this, and this is why I think thinking and sequencing is useful. You still have to, in that case, create a gradient. And if you think about it this way, if the primary compensation involves little tiny baby musculature, and the secondary involves the big dogs, I'm concentrically biasing the back side harder than I am the front side. In theory, there's a higher concentration or volume of stuff on the front side. It's like the battle between the transversus thoracis and my erector spinae. Who's going to generate more force And how is that going to change where air goes? Ergo. Well, the erector spinae are bigger muscles, so they can push harder forward. So there's going to still be more air in the front, even though it will still be restricted. So what you have to do is you got to create a gradient. So I'm going to push where the air is on the front side back first in that case. Then if I open up that person's backside, that doesn't sound good, but you know what I mean. If I open up or I eccentrically orient the posterior aspect of that body, well, now I have another gradient. I got stuff in the back. You got junk in the proverbial movement trunk. Then you can push it forward safely without problems. If I went out of order and I work with that narrow primary compensation and secondary compensation and I push air into the front first, well, that could work, but you're battling against a stronger gradient because I have an area of high concentration of stuff already. It would be like Somewhere Studios is kind of filled to the brim and we're trying to push more peeps in here. We don't want that. I mean, the room ain't that big, good Lord. So you want to go where the secondary compensation is first because that musculature and those tissues are what are creating the gradient. So it is important. It's incredibly important in that regard. So if you have, let's say your first example, a wide ISA with primary compensation, they're concentric on the back, eccentric on the front, and a narrow with secondary compensations. So they're concentric front and back. For the wide, you're going to do things to eccentrically bias the back side. And for a narrow, you're going to eccentrically bias the back side first and then go concentric. So that matters. That's important. But then, now you're saying, well, Zach, it looks like the operation is still the same. You still got to push air in the back. So what's different with a narrow versus a wide? The difference is with addressing the concentric bias on the person with the primary compensation, you have to manipulate that person's structure to improve the movement dynamics in that area. The reason why the wide ISA has a concentrically biased backside is because that's the first adaptation to that person's structure. So what we have to do in that case is make the structure dynamic. So to improve posterior expansion on a wide ISA, I don't always drive like true posterior expansion with low reaches. Instead, what I do is I think about compressing the sides of that person to then change the shape of the relative shape of the rib cage to encourage the posterior expansion. Whereas for a narrow ISA, I would do a low reach or something similar to encourage the posterior expansion. Let me unpack that a little bit. A wide infrasternal angle, if I looked at them from the top down, they're going to be larger laterally, medial lateral, and smaller A to P. So if I compress A to P, in theory, I will expand front to back. If I do something that compresses the sides, maybe this is a side plank, could be a suitcase carry, could be anything like that, then that side compression will encourage A to P expansion, and a lot of times you'll see some nice changes in mobility from that. More also, too, what I've found with a lot of wides is when I do attempt low reaches, for some reason they just overpeck a lot of it and can't get the legit posterior expansion we want. To me, I found it a lot easier by compressing the sides. Whereas if I do that same movement with a narrow who has secondary compensations, well, they're already compressed on the sides. So that's going to magnify the problem. However, if you do a low reach, that doesn't compress the sides of that person's ventral cavity, and you can then achieve the posterior expansion that you so desire. Flip-flop that with the second scenario, a narrow ISA with primary compensations and a wide ISA with secondary compensations. Because this one, I think, it magnifies it even further. So the goal with both of those people is we need to get expansion on the front side of the body. If we're talking about reaching, if I'm trying to get front side expansion, I'm going to reach from 60 to 120. That's why with a narrow ISA, a lot of times I will cue just forward reaching at 90 degrees. And the reason why that is because that will allow for expansion of the rib cage laterally. It will squish the front and back a little bit so you can get that lateral expansion, and life is good. And that a lot of times will improve your anterior measures, your extension, adduction, internal rotation. If I do the same forward reach with a secondary compensated wide, well, remember, they still have that concentric bias on the back. And when you reach at 90 degrees of shoulder flexion, because the scapulae are in more external rotation, don't worry, I got a debrief that I'll link that will dive into that. Because the scaps are more ER'd, you're going to have a concentric bias on the back side. So guess what, folks? When I reach forward like that, I'm only reinforcing that bias backside. So I'm creating more tension on the backside of the body. And then I have thrown off that gradient because I have all of this altered tension going on. Whereas if I do a 120 degree reach, well, now I have a situation where I get better serratus anterior recruitment, which compresses the rib cage laterally. I don't get as much pec involvement. I have the upward rotation. A lot of times the scaps will be downwardly rotated in that case. And because as I get into more upward rotation, even though I'm more ER'd, the scapula begins to reorient into the scapular plane, which can in theory allow for some posterior expansion. So subtle difference, but respecting the structure allows me to get different outcomes. And it's not this plug and play where once the person's limited everywhere, the ISA doesn't matter. The last component that I would say matters with the infrasternal angle in this regard is the breathing strategy used. Because regardless if you have primary or secondary compensations, in order to make the infrasternal angle dynamic, you still have to use the same breathing strategy. A narrow is going to do softer exhales because I don't want to create all this excessive tension in the lower rib cage, which would negatively impact the diaphragm's ability to ascend. For a wide, I need a little bit more resistance to close the lower rib cage so we can get the diaphragm to ascend. So that's where you're doing an impression of a windy day is effective. So that's why understanding the primary and secondary compensations, how it relates to the structure of the ISA, still matters, even if a person has similar restrictions. I could conceive of two people having the same restrictions, the same measurement findings, but because one is built differently than the other, one's a narrow, one's a wide, you could go about it on different paths and get a good outcome. Now, are you going to screw someone up because you measured the ISA wrong and you went down the wide protocol when you should have went narrow? Probably not. That being said, I do think that going about it in this fashion ought to increase your probability of success because it's respecting the concepts of gradients, it's respecting that person's structure, and if you can do those two things, you will likely create some excellent movement adaptations in your people, and you ought to be in business. Oh, Dan, the man. What's good, my guy? Zach, if a narrow has ER and IR limitations, you say they should address ER first. If they address both ER and IR simultaneously, what happens? Ooh, this is a good one. I've been doing this a lot more, actually. So if you address ER and IR simultaneously, that's going to get you some A to P expansion to some degree. And a lot of times that can be very useful and effective. This is where doing trunk rotation or hip shifting can be useful. So I'm totally cool with that because you're still respecting the concepts of gradients. And in fact, being able to do that might help even further because anytime you throw rotation in the mix, you create greater excursion of movement than if you do things straight plane. For example, if I reach forward with both my arms, my trunk don't move a whole lot. But as soon as I reach a little bit forward with my right, ooh, the movement capabilities in my thorax are dynamite. So you can totally work on both at the same time because it still respects gradients. Assuming that your person can stack. Do you even stack though? Probably not. So continue to work on that first before you get wild and crazy. Coach Franz Former, What cueing would you use for wide ISA breath work? Cues I like. So for a wide ISA, I need to create greater lateral compression of the rib cage because I got to make the infrasternal angle smaller. So you're going to do a pursed lipped or kissy face. Go ahead and screen cap that one more time. Position for that person, because if I close my mouth a little bit, I have greater resistance to exhale out against. This is where straws, balloons, spirometers, all of that is useful for this particular population. Second thing, you're going to cue them to exhale slowly in that position. You don't want this or all the other crap that people do. You still want a slow exhale, because if you go too hard, you go too ham on your exhale, you're going to recruit too much superficial abdominal activity like the rectus abdominis. You're not going to get that lateral closure of the rib cage, and you won't restore movement options. So you want to slow cook the exhale. Cues that I like to give for these folks are pretend you're doing an impression of a windy day. Blowing a pinwheel, flickering birthday candles. Those have seemed to be the most effective. You're the big bad wolf. Pretend you're trying to huff, puff, and blow the house down, but slowly. Those have been kind of my big three. And then also demo as much as you can, which, interesting, is really tough in these COVID times, because if you're wearing a mask all the time, you can't really show the exhale. So that's where I think the other cues can be useful. I think that's a good stopping point for us today. I want to thank all of you beautiful, sexy, outstanding people for tuning in. And IG, God, thank you for a bunch of awesome questions. This was a lot of fun. So I appreciate you tuning in. If you want to learn more, there's a place where you can find me. It's a place called home, folks, and the home is zachcouples.com. While you're there, subscribe to my newsletter, because I got so much free stuff for you, it's not even funny. Look, I'm serious. I can get you access to my free course, Human Matrix Foundations, which goes into a lot of the anatomy, biomechanics, normal mechanics of respiration, lots of things to help prep you to learn the stuff on the debrief and such. You'll also get the Common Compensations workbook, which will really simplify the coaching into the two strategies that we talked about today, concentric front, concentric back. So definitely check that out. You'll get like 5 hours of talks and a free acute chronic workload calculator, and you'll get goodies from me every Friday, so you can get some cool stuff on the internet. If you need hip-hop recommendations, you need good stuff to read, Zach will help meet your needs. So there's that. While you're there, I got a lot of services too. The first is Human Matrix, my seminar. I got one in 2020. Assuming the COVID gods shine upon us. November 7th and 8th in Charlotte, North Carolina. But folks, if you're thinking 2021 might be a better year, although can we at least agree that 2020 has been great for music and memes? I mean, that goes without saying, I think. So the one this year, though, November 7th and 8th, Charlotte, North Carolina. Next year, February 20th and 21st, Atlanta, Georgia. April 10th and 11th, Warren, Ohio. May 1st and 2nd, Minneapolis, Minnesota. May 29th and 30th, Boston, Massachusetts. August 14th, 15th, Ann Arbor, Michigan. September 25th, 26th, Wyckoff, New Jersey, which is outside of New York. If you want hands-on coaching, cueing, you really want to dive into this material, you want to make sure you're stacking well, you better come to one of the seminars. It's going to be off the heezy for sheezy. So I hope to see you there. Other services that I have available. Movement consultation. If you're thinking, oh man, I'm limited in flexion, abduction, ER. And you know what? I happen to be limited in extension, adduction, and IR as well. What the hell do I do about it? Well, your boy Big Z can tell you what to do about it, because I can remotely, 100% remotely, COVID-free, perform a consultation on you where we look at all of your movement capabilities. We find out where you're restricted. We coach you on the spot to see how we can improve your movement restrictions that you got on the table. And by golly bows, if I can't make a change in the tests, you get it free. So go ahead and check that out. Sign up ASAP. You can also do that from a training perspective. So if you want to improve your movement capabilities, but your fitness is whack and you want to get it on point, then you can also sign up for online training with me. Right now, I currently have a wait list, so you can go ahead and hop on the wait list, and hopefully we get you in sooner rather than later. I may have a couple openings this upcoming month, so please check me out in that regard. If you want to learn how to address primary and secondary compensations with your supreme clientele, then that's where you want to go sign up with mentoring with your boy, because what we'll do is I will run you through any didactic limitations that you have specific to you, answer your questions. But most importantly, and this is why I think has been key for the mentees to be successful, is you're going to go execute some stuff with your clients. You're going to send me videos of you coaching. You're going to send me videos of you testing. I'm going to keep you accountable for deadlines that you may be possessing. And then with the people you're working with, you will no longer be guessing. You'll be getting gains left and right for your peeps. So definitely check me out on the mentorship side. Once you've scoured ZachCouples.com, I would encourage you to check me out on Apple Podcasts and Stitcher. Search The Zach Couples Show. Because guess what, folks? There's 132 other debriefs out there, and, I wasn't always drinking Olipop back in the day. So you might just want to listen to me. That's especially going to be the case because, fingers crossed, I got a couple podcasts in the mix that I'm hoping to release soon. So you'll definitely want to check me out there. I got some really good interviews coming up, so I think you'll like that. So while you're there, please leave a review so the fam can keep growing. I'm also on the social medias, so check me out there. Facebook and Twitter. ZCouples is the handle. On that Instagram, baby, Zach, Z-A-C, Couples, C-U-P-P-L-E-S, is the handle. And last but not least, folks, I'm on YouTube. I put out a bazillion exercises out there to work with you. A lot of them, not all, one day I'll get there, but a lot of them have indications for when you should use what. Maybe play with those things. See if it helps your movement capabilities get on point. So check me out on YouTube. Just search Zach Couples. If you do that, you'll find me. And, you'll hear me say, give it a shot, a bunch. So there's that. Thank you so much for tuning in. You've been a beautiful, sexy, outstanding audience, and I hope you stay safe and healthy during these wild and crazy times. Keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.